Okay, I would like to hand over now to Martin Whiteley, who's joining us all the way over in Western Australia. Martin's from Curtin University. I'll allow him to introduce himself, but he's going to be talking about boys and the overprescription of ADHD. Thanks, Martin.
Yeah, thanks, Neil. I'll just try sharing this screen. Right. Just a little bit about myself first. So I think it's relevant that I was born in '59. I think about 20 years too early to sort of be part of the explosion in ADHD prescribing. But I'm certain that if I'd been born 20 years later, I would have been one of those children that would have qualified for a diagnosis of ADHD. Whether my parents would have actually gone down that pathway, I'm not sure. Certainly would have made the diagnostic criteria. Look, I first became interested in the topic when I was a teacher at a boys' grammar school, a very wealthy western suburbs. It's the opposite of the East Coast, western suburbs, Perth Grammar School, and there were very high rates of prescribing at that school. And then I went on to represent a electorate in state parliament for 12 years that was actually the opposite, demographically the opposite, but it was also an ADHD prescribing hotspot. When I actually looked into this, the two things that the areas had in common, they were serviced by very enthusiastic prescribers. So sometimes some of those other factors that have nothing to do with the demographics of the population, but rather the attitudes of the prescribers, actually accounted for the difference in prescribing practices. Right. Yeah, so after leaving politics, I was a mental health advocate. I've written a book on ADHD. I've got a website and blog, and I will make this presentation available so people can go to any of the hyperlinks that they're interested in. My PhD thesis was on looking at basically regulatory capture and ADHD policy in Australia. Really, what's the influence of the pharmaceutical industry on the guidelines and the treatment of ADHD in Australia. I've also published a number of papers. Probably the three most prominent papers relate to, or the two most prominent relate to the influence of birth month of birth on the probability of being diagnosed and medicated for ADHD. The first one concentrated on Western Australia. It was published in the Medical Journal of Australia in 2017, and the second one looked at the phenomenon internationally. It was a systematic review of studies, 22 studies that had covered over nearly 16 million children internationally, and looked at the effect of month of birth on the probability of being born ADHD. Probably being diagnosed with ADHD and medicated for ADHD. And the last paper that I just published last month actually looks at the relationship between ADHD prescribing and the illicit use of ADHD medication. So I'll just talk briefly about each of those studies. The West Australian study looked at, in 2013, we had a look at the patterns of prescribing for all children and the month of birth for all children diagnosed with ADHD in Western Australia. A fairly large scale study. There was about 7,000 children diagnosed and medicated for ADHD in 2013 out of a total population of about 300,000. And we found that amongst the youngest in class, which in Western Australia was those born in June, who were actually 11 months younger than those born the previous July, because our school year intake runs from July to June. And in Western Australia, unlike other states like New South Wales, there's very strict adherence to that, so there's very little flexibility moving outside of that. So we were able to do this study in Western Australia, and we found that amongst primary school children in years 1 to 5, you were approximately double the risk if you were born in June as being born the previous July, which, very interesting, we thought. And so we had a look at international studies to see if this phenomenon was worldwide. And we found that globally it is the norm internationally for the youngest children in a classroom to be at increased risk of being medicated for ADHD. Now, this isn't explained by seasonal variations. For instance, in the US, where they have very different school intake periods, but the same seasons, the pattern of the youngest children in class being medicated was consistent. So if the school year intake ended in April, the kids born in April were much more likely to be medicated. If it ended in September, the kids born in September were much more likely to be medicated. So it had nothing to do with seasonality of birth. And the other interesting thing we found was this phenomenon occurred. It didn't matter if it was in very low prescribing countries like the Nordic countries or Taiwan or very high prescribing countries like the US. The relative risk was the same. In other words, it was just as strong. The relative effect was just as strong. So children who were born in the last month of the school year or the last quarter of the school year intake were much more likely to be medicated than kids born in the first than their oldest classmates. Now, I think the most probable explanation of this is that teachers play such a central role in the diagnosis of ADHD. They obviously don't diagnose it, but they provide the evidence, a significant part of the evidence that's used to diagnose ADHD. So it raises concerns about whether teachers are taking account of the differences in maturity levels that are, perfectly reasonable and understandable that occur simply because children are younger than their classmates. The latest bit of research I did looked at the illicit use of ADHD medications in Western Australia. And I've concentrated on Western Australia, not only just because I come from here, but also because we do tend to have more robust or more complete data sets in Western Australia, resulting from a stimulants regulatory scheme that was put in place in the early 2000s. And we found that we've made a lot of findings, but probably the most startling finding was that in 2017 in WA, for every high school student who was prescribed dexamphetamine, and we didn't have the figures for Ritalin, and we didn't have the figures for the other forms of ADHD drugs, but for dexamphetamine, for every student that was prescribed dexamphetamine, which is about 1.2% of the population, 2.5 kids had, or 2.5 high school students had used it illicitly. So we found that 1.2% of the high school population had been prescribed dexamphetamine in 2017, at some time in 2017, and 3% of the population had actually used it illicitly. So that was a startling finding, and it should not be surprising, I think, given that the ADHD stimulant medications, which is the vast majority of medications prescribed for ADHD are stimulant medications, all carry boxed warnings for the potential for diversion and abuse and addiction. I think any debate about ADHD or any discussion about ADHD should start from the diagnostic criteria. And the most important thing to understand is there is no biological marker that's diagnostic for ADHD. I've been involved in this debate for 25 years now, beginning as a teacher, then as a politician, and now as a researcher. And I can't count the number of times I've heard the promise of an imminent genetic or test or brain scan that's about to reveal, that offers great promise of a diagnostic marker, but all of those promises have proven to be false or overblown at least. So even if we did find a genetic marker for ADHD, in my opinion, all it does is show a difference, a genetic influence on behaviour, which is totally understandable. It doesn't actually make the diagnostic entity a disease. To be diagnosed ADHD, a child's got to display 6 or more of 9 inattentive or hyperactive impulsive behaviours. So you can show 6 of 9 behaviours that sometimes called passive ADHD, inattentive ADHD, that tends to be diagnosed relatively more in girls than boys, or 6 or more hyperactive impulsive behaviours. Now that's an important point to make, because in 1994, the definition of ADHD changed from having to show 6 of the inattentive and 6 of the hyperactive to or. So instead of being inattentive and hyperactive impulsive, it became inattentive or hyperactive impulsive. So the diagnostic bar was lowered, and not surprisingly, there was a resultant increase in prescribing rates. The symptoms are supposed to persist for at least 6 months and be maladaptive and inconsistent with the developmental level. And I'd suggest that the research that we did about the birth date effect indicated that there were developmental level wasn't actually being taken into account in the case of the relatively young children in class. These are the inattentive criteria, the 9 inattentive criteria: making careless mistakes, failing to finish schoolwork, chores, difficultly organising tasks. My favourite, or least favourite, I guess, is F. Often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort, such as schoolwork or homework. I would have thought disliking homework was a fairly normal childhood response. And these are the hyperactive criteria: fidgeting, leaving your seat when you're expected to remain seated, running about or climbing excessively, having difficulty playing, being on the go, talking excessively, blurting out answers, interrupting. And you'll notice they all begin with the term often. There's no definition in the DSM, the Diagnostic and Statistical Manuals of Mental Disorders, that actually defines these diagnostic criteria, what is often for a 5-year-old as compared to a 17-year-old. So it's really up to the clinician to interpret what is meant by often and what's an age-appropriate level. These are just some of the factors associated through the research with an increased risk of an ADHD diagnosis. Gender: boys are about 3 to 4 times more likely to be diagnosed than girls, and I'd suggest that's because some of the hyperactive behaviours tend to be more typical in boys. There's been a big effort to actually market, I'd use the word market, to market passive ADHD or inattentive ADHD as being underdiagnosed in girls, and it's even been portrayed as a gender equity issue, but I'd suggest this is one area where girls certainly don't want to catch up to boys. Relative age, which I've discussed, teacher attitudes through ADHD, and I saw that when I was a teacher. There were teachers that believed in it and there were teachers that didn't, and that influenced the chances of a child being recommended for assessment. There's ethnicity of students and teachers, highly variable, but depending on where you are. But in the US, for instance, white kids are far more likely to be diagnosed than Hispanic kids or African American kids. And there's theories about angst, parental angst, about performance that are associated with that. But I haven't got time to go through all of those. But you can see there's a whole range of reasons there, potential reasons. And if you go back to the diagnostic criteria, if a child is sleep deprived, for instance, I don't think it's hard to understand why they're not paying attention in class. If a child has suffered sexual abuse, and I'm not suggesting this is a common cause, but I have known of some cases where children have been sexually abused, and that's been missed in the diagnostic process, and they've been put on stimulant medication, sometimes with tragic consequences. So there's a whole host of factors that are associated with increased risk of being diagnosed with ADHD. And again, all of those are hyperlinked. So if anybody wants to go back to the research, that they can do it at the click of a clicking on them.
Martin, could you wrap up in a couple of minutes, please?
Yeah, I'll do it as quick as possible. How big is the ADHD industry? Well, globally, sales of the ADHD industry were about 25 billion Australian dollars in 2018. They're projected to grow to about 37 billion by 2025. There was about 60,000 children on ADHD medications in 2009. That grew to 107,000 in 2017, and given the incomplete data that's come through, and I won't go through it, I estimate there's probably more than 130,000 children on the medications now. And just this is the last slide. I'll finish on this slide. There are variations in rates. New South Wales is currently marginally the highest in the country, Western Australia back in the 1990s and through to the mid 2000s was the highest. We were about 3 times the national average, but we put in place some prescribing accountability measures that brought that under control, or brought down rates. There was about a 50% decrease in West Australian rates. And when we brought those prescribing accountability measures in place, we found, for instance, that one particular paediatrician had diagnosed 2,077 children in a 17-month period. I probably haven't got time to go through it, but there's a range of views as to ADHD. Proponents who believe it's a common genetically determined neurobiological disorder. Critics who believe, some who believe it's overprescribed, and those who, like myself, believe that it's actually robs us from understanding of what's a child's individual circumstances, and that we really need to go bury down into each individual child to find out what's going on in their lives if we really want to respond to their individual needs. So I'll leave it there.
Yeah, thanks, Martin. That was an astounding amount of information crammed in there. So many important points that you raised there, and probably things that none of us have even considered before. There's a question in the chat box from Amanda. Have any of your studies seen a misdiagnosis between ADHD and trauma, or anything related to preservatives in foods and allergies to preservatives in foods?
They were 2 hyperlinks actually mentioned that. There are some studies that show that food additives, there is an association, and there are studies that show that trauma, like sexual abuse, is associated with an increased risk of diagnosis of ADHD. But none of those things are global explanations. And if they were, each of them probably only, explains a tiny fraction of the proportion of children that are diagnosed with ADHD. So that's part of the difficulty in actually setting out a competing message, because the other side of the ADHD debate will argue that their solution, which is typically medication, actually will alter behaviour in virtually all children, as it does with all human beings. If you take a low dose of, well, not all human beings, but the vast majority of people who take a low dose of amphetamine in a controlled manner, it actually alters their behaviour. So yes, there are those studies, and they are, time limited me from going through them individually. But yes, they're there, and the hyperlinks are available.
Thanks. Is there another question? Something about, in the box, something about,
yes,
ADHD and mental health, and then I'll go to John after that. So what are the impacts on mental health, Martin? Is one of the questions in the chat box.
Sorry?
What are the impacts on mental health?
Well, I think that's a very complex question, but there's a number. I mean, the drugs themselves can cause psychosis. But even greater concern, I guess, is the fact that often the underlying cause gets missed, because we accept the label of ADHD, which John Giardini is a professor of psychiatry from Adelaide and a very good friend of mine, describes as an unexplanation. It stops us actually looking for the underlying cause of the behaviours. So, real factors like trauma, like sexual abuse, like bullying, can all get, social isolation, can all get overlooked. And the child's behaviour can be attributed to the label ADHD, when really it unexplains what's going on in the child's life.
Right, thanks. And John Shearer, you had a question as well.
well, it wasn't actually a question, but probably just a comment, because I worked in juvenile justice for 10 years, and over that time, on average, a unit in juvenile justice holds 15 boys, and I was a mentor of those boys. And on average, over that 10 years, I would say 9 out of the 15 were medicated. And I'll support Martin Whiteley in it's overprescribed, it's over diagnosed, and it's just a lot of rubbish, really. So I just wanted to make that comment in support of Martin Whiteley with my 10 years of juvenile justice and my observations. And I don't know how we can stop it. It's ridiculous.
Yeah, no, thanks, John. That certainly backs up my experience of having worked in juvenile justice as well. Look, thanks everyone for those questions, and thanks again, Martin, for your presentation.